Hello, my name is Seema Radhakrishnan. I'm a rehabilitation physician. I work at a 20-bed rehabilitation ward in a public hospital in southwestern Sydney, Australia. I thank Annabelle Dharmali, who was a ward physiotherapist and research assistant who helped us conduct the study as well as help me with the preparation of the slides, and Aging Futures Institute at UNSW for providing funding to conduct the study. Exercise therapy is a crucial part of inpatient rehab. We know this is true especially for older population. Rehabilitation patients need regular exercise and mobility to reach their goals and bounce back, whether that be from a fall or a medical illness. When we think about exercise and rehabilitation, a lot of us think about physiotherapists and the role they play in improving mobility, strength, and function. But it does not always have to be limited to physiotherapists to provide the service. What if we could utilize other workforces to provide additional therapy, and this would still lead to better outcomes? We do know that the rehabilitation nursing focuses a lot on getting patients as independent as they can be with their day-to-day activities. And we felt that the nursing student workforce, when they posted to the rehabilitation board, could provide that alternative workforce. We used the Sachs Institute of Translational Research framework to provide a structured approach to the implementation. So Sachs, this translation research framework helps us to understand how to move from healthcare innovations from a concept stage to sustainable practice. It begins with testing the feasibility and effectiveness in controlled environment, then expands to diverse clinical settings, followed by scale-up and long-term monitoring. So what do we know? We know from the available data that increasing intensity of therapy can lead to improved outcomes in older patients, particularly after falls, hip fractures and hospital-acquired deconditioning. And a lot of these studies, for example, Lara Kimmel's study in acute hip fractures and Allende's study, they were mostly done in acute settings. Lara Kimmel's study used physiotherapy students and allied health assistants to provide that increased therapy intensity. So we do know that these programs do work under very controlled conditions. So where do we go from there? We explored whether this approach could be replicated in subacute care. So that is the replicability and the adaptability of the intervention. So using this framework, we implemented a high-frequency sit-to-stand exercise program in the subacute ward. The sit-to-stand exercises were chosen because they are safe, effective, and suitable for delivery by a supervised alternative workforce, and we leverage pre-registration nursing students to deliver the intervention across the patients. And these included patients with diverse impairment in an Australian public hospital setting. The study demonstrates the potential to adapt and scale evidence-based, high-intensity rehabilitation using innovative workforce models in subacute settings. So we go through the background, brief overview of the boost, the results, including the 3 themes that evolved from the qualitative analysis, and the key takeaways. What we do know about exercise in inpatient rehabilitation. So we do know that increased therapy dosage can lead to improved mobility, independence in activities of daily living, and reduced risk of institutionalization. We know that the rehabilitation programs work best when they are delivered by the multidisciplinary team. We used Consolidated Framework for Implementation Research, or CFIR, to assist with implementation planning and identify and address facilitators and barriers to implementation. In the CFIR framework, the innovation is the thing that is being implemented, which in our case is increased intensity of exercise. Then it also looked at various barriers and facilitators in a broad scope of individual barriers and facilitators. So that could be for the patients or the staff that are delivering the therapy, or the other support staff. The inner setting, which in our case was the subacute rehabilitation ward, and the outer setting being the bigger hospital network and the public health system in general. The CFIR also helps us to have a look at the process in general, which is about how the strategy or the thing is being implemented. The boost comprised of one-on-one fully supervised exercise sessions delivered at the patient's bedside, which could be either bed or chair-based exercises. The exercise and the dosage were selected by the ward therapist and delivered by nursing students during weekdays and allied health assistants during weekends. And this was in addition to the one physiotherapy session they would have during the weekdays. Our ward did not provide any weekend therapy. Now you might ask me what this 2.0 is. Well, the 2.0 is because there was a 1.0 where similar exercises were delivered to older patients recovering from hip fracture in an acute ward setting, so in an orthopedic ward. We used the same set of exercises and just changed the setting that they were being used, and also broadened the diagnosis to include hospital-acquired deconditioning and falls without fractures. The context in which the public hospital was situated, so we catered for rehabilitation across 2 local government areas within our local health district. Majority of the patients spoke a language other than English at home. Around 50% of them needed an interpreter. Vietnamese, Assyrian, and Arabic were the most commonly spoken languages, and the patients mainly belonged to a lower socioeconomic group, as seen on the SAFA. Our facility, it was a 220-bed hospital, metropolitan hospital. We were not a tertiary hospital. We had around 30,000 admissions per year and offered services in acute medicine, level 4 ICU, emergency department, maternity, pediatrics, as well as elective orthopedics and some general surgery. The study aim, we took a deep dive into the experiences of patients and carers as well as staff during the implementation period, and we explored conversations that were made about its uptake and feasibility. So the qualitative analysis helped us to identify 3 main themes, concepts under 3 main themes. One was perceptions of the boost program itself, perceptions of the implementation strategy, as well as contextual factors that affected our implementation. So we based this on the overall CFIR framework, the innovation, the inner and outer setting, as well as the process. Talking about the boost itself, it was positively received by all involved. The nursing students saw it as an opportunity to improve their clinical skills and glean insight into the rehabilitation scene. Ward staff valued the increased dosage of therapy and believed it would contribute to faster recoveries and discharges from hospital. Patient reflections revealed a more nuanced experience, such as how they valued increased social interaction and engagement with meaningful activities. For example, one of them said it was something to do apart from just being in bed all the time. However, there was some pushback from the carers who seemed unsure if the extra exercise would bring any additional benefit to patients, especially in the context of old age, frailty, and pain. These are some quotes from the patients, and I'll just give you a few seconds to read these quotes. Under the perceptions of Boost's implementation, several topics were raised. One was regarding the value of Boost. While it was valued, many students felt ill-prepared, lacked the confidence to deliver the therapy, and were worried about causing more pain and distress to the patient. The nursing students who participated in the implementation, about 2/3 of them belonged to, they were first year medical students doing their first or second year clinical posting, so they were not very experienced, and at this stage in their journey, they were more focused on learning how to do regular observations, learning how to understanding more about medications, and also developing their communication skills with the patients. They were not very confident in providing physical assistance. However, there were some students who had some prior experience in exercise and therapy by their work experience in other types of work. Like one of them was a gym trainer, so was very, very confident and in doing what was supposed to do, and in fact felt that the exercises were too easy. So we had the two extremes. Boost was also seen as a lower priority amidst other placement responsibilities and established nursing routines. Nursing staff believed that better guidance and training on how to integrate the Boost sessions and increased physiotherapist engagement with the nursing workforce could help to facilitate a change in culture of getting patients up and moving by the nursing staff rather than waiting for the physiotherapist to do that. However, the allied health assistants were already familiar with the hospital cultures. They were already involved in therapy, provision of therapy in the weekday setting, and hence the weekend Boost sessions were greatly valued by the patients, and they were very confidently delivered by allied health assistants. These sessions, the weekend sessions, were seen as a continuation of therapy across the week. Other strategies that were involved in the implementation, including the use of printed handouts that were kept near the patient's bedside, the structure of the sessions being one-on-one, were noted to be very effective in bridging the language barriers and enabling increased opportunities for meaningful interaction. In terms of the third sort of broad area, which is the contextual factors affecting implementation, it involved the outer setting, which was the hospital or the local health district as well as the inner setting, which was the rehabilitation ward itself. So when we looked at the contextual factors, a prominent discussion point was raised by the nursing workforce. So this was the students, the staff, and the nursing student facilitators. The facilitators provided the support through the students and provided supervision to the students in orientation of what was required, as well as the ward activities. So one of the main themes that came out is delivering the exercise within my scope. Was it within the scope of nursing? Some of the nurses, especially the first new grad nurses who was involved in supervision, felt that the boost fell solely within the scope of the physiotherapist, while more experienced rehabilitation nurses felt that this was still within the scope of a rehabilitation nursing practice. The difference in nursing and allied health placement processes were very different in our facility. I think, in fact, through the whole of the local health district. And many of the ward nurses did not feel that connection. They felt that they lacked authority over the students, as these supervisory role mainly fell on the facilitators. Most of the facilitators were external facilitators. They were appointed by the university, and they had no relationship to the ward itself. There were some facility based nursing student facilitators who were employed by the local health district and who felt that there was more involvement if the supervision was provided by them. The external facilitators went in and out, so that we didn't have that consistency with the external facilitators. Frequent turnover of staff, onerous processes including recruiting new staff, the project funding itself within needing to finish the project within the funding timelines, all limited the scale up and efficiency of running the boost. To conclude, we've come to the last slide. Our research shows that there is a potential to improve the subacute rehabilitation scene using existing resources, and that these may be transferable across multiple wards and patient settings. However, internal and external influences such as readiness for change, especially for the carers as well as the nursing students and staff, personal beliefs and hospital policies can pose barriers to successful implementation. Our study only scrapes the surface of this emerging research, utilizing our young and developing workforces to bring about positive outcomes for all. But this should only be the beginning. I've included some references in the slides, and this is my email. If anyone wants to get in touch and try the exercises in their own settings. I've also attached a link to the article on which this presentation is based. Thank you.